Thank you. Just an added thank you to the organisers and for Michael for asking me to speak here today. Consider that an honour, so thank you. I've been asked to speak about cervical radiculopathy today. Cervical spondylosis causing nerve root compression in the foramen, be that by anterior disc protrusion or uncle osteophyte or posterior osteophyte, is not an uncommon problem. But despite how common this problem is, discussion continues about the best way to approach it. And when you talk about the options, we have the usual arguments about surgery versus conservative management, about anterior versus posterior approaches. In anterior approaches, whether we fuse the spine or do disc replacement. In looking at the program, it actually looks like there's going to be all of those options covered here today. The next talks about anterior approaches and the next talks about posterior approaches. Underlying those are really three principles. How can we adequately decompress the nerve, and how can we do so with both minimal trauma to the patient and, as a subset of that, with motion preservation? So I'm going to leave those approaches to the next two speakers and thought that first I'd just talk about some recent developments in terms of evidence-based guidelines that have been published, but also some of the other novel techniques that I'm not completely familiar with, but ones that employ those principles of nerve decompression with minimal trauma to the patient. So just in terms of the evidence-based guidelines that have recently been published, the North American Spine Society in 2010 published a 180-page good bedtime reading document that's available for download free from their website at spine.org. And I just wanted to go through a few of their key recommendations. Some differ a little bit from what I would have said before I read this document. And some of them seem very simple, but even though they are simple, I think it's important that we're aware of it, both as a yardstick by which to measure our own practice, but being cognizant it may be a yardstick by which others judge our practice as well. So the first question that one of the first questions was, what was the natural history of cervical radiculopathy? And there was really not great evidence, but they came up with a consensus that in most people it may be self-limited. In terms of diagnosis, they actually recommended MRI as an initial investigation, not unsurprisingly. However, I did find it interesting the MRI was considered less accurate than CT myelography, but they recommended the less accurate investigation first because of the risks associated with CT myelography. And they actually came up with a grade B, which was the highest recommendation they gave of anything, that in conclusive cases should actually have CT myelography performed. In terms of nerve root injections, they said they could be considered, but went a lot into the evidence about the volume of injectate. If there's more than 1 mil of injectate used, it will actually be demonstrated to spread to the other nerve roots above and below, and can therefore not be considered truly selective, and so a nerve root injection at one level may lead to relief at another level. In terms of EMG, they found there was insufficient evidence, and just to digress from the evidence-based, this is just a paper, I think, from last month's Journal of Neurosurgery, where they did intraoperative nerves mapping with EMG recording, and just showed that there was actually quite a wider variation in innervation than was previously thought. So if we take the biceps muscle here, whether we stimulate a C3, a C4, a C5, or a C6 nerve root, you could get a biceps EMG response in 25 to 35% of people. And so your EMG abnormality of a biceps EMG abnormalities may not necessarily reflect a single nerve root problem, and that maybe underlies the reason that the evidence for EMG is not particularly good. In terms of treatment, for pharmacological treatment, they were unable to find any significant, adequate literature, and the same applied for physical therapy. But they threw in a consensus statement that they all agreed that manipulation would lead or may lead to worsened symptoms and should be considered carefully. And they did note that all these other ancillary treatments are noted in uncontrolled case series to lead to clinical improvement. In terms of epidural steroid injections, not for diagnosis but for treatment, they said they could be considered as part of a plan. But the question that, the most obvious question is whether surgical treatment results in better outcomes than medical or interventional treatment alone, and they recommended it for the rapid relief of symptoms as a grade B recommendation. And then to counter the people say it may not be sustained, they said that looking at studies that followed patients out to 4 years, that favourable outcome was maintained. In terms of the perennial argument that we've alluded to about whether, I think I'll just skip on there, about whether anterior or posterior is better, they did say that both anterior and posterior can be used and they may have comparable outcomes, but then as a consensus statement stated that for central or paracentral disc disease, the ACDF may be preferred. In terms of the novel techniques, I just wanted to mention they're, like I said, techniques that employ those principles of adequate nerve decompression with minimal trauma to the patient. One of the criticisms of traditional posterior cervical foraminotomy is the muscle dissection required, and so tubular approaches have been developed in order to try and minimise that muscle trauma. It was initially described in cadavers on a paper I think Dr. Kim may have been an author on, and then later reported in clinical series. But these were actually using an endoscope, equipment that we may not all have readily at hand or be equally familiar with. And so, as Dr. Kim mentioned earlier, the use of a tubular retractor has been then combined with a more standard microscope, operating microscope, first described in 2007. And through that, directing that tube at the symptomatic level can allow adequate decompression. This tends to be my preferred approach for doing a cervical foraminotomy. So if you have someone who has unilateral bony or lateral disc herniation causing foraminal stenosis, you can, through a tube, and that's an 18mm diameter tube, get access to the nerve, and if you do, sometimes the disc usually isn't that easy to see. You usually have to drill a bit of pedicle to see it. And you can get quite good decompression with fairly minimal, not that it's about the scar, it's about the muscle underneath, but it's a fairly minimal type of approach that we use. I don't know what the exchange rate for a quarter next to a 10 cent is, but for Dr. Kim's pictures. In terms of evidence for this, there's really only 2 published studies. The paper on the left is actually from Calgary, where I did my fellowship, and one of the co-authors is Mark Winder, who's a neurosurgeon in Sydney at St Vincent's. And in terms of comparing their open approach laminoforaminotomies to minimally invasive ones using that technique that I've described, they found significant improvements in terms of blood loss operative time and the post-operative analgesia required. The alternative operation, an alternative operation that minimises trauma but it is said to adequately decompress the nerve is the anterior cervical foraminotomy, an operation I haven't performed myself but described by Dr. Joe in 1996, and there have been sporadic case series of this since. It involves a standard extensile exposure of the anterior cervical spine with actual resection of the longus colli to allow exposure of the uncus in its hole out laterally. They drill then the uncus off to remove the bone. It's said to be disc sparing because they're out that far laterally, but obviously the challenge, and maybe the reason it hasn't been universally accepted, is the vertebral artery sitting out laterally to that. Dr. Joe continues to publish about it and now describes 3 variations, and so if you ever want to try, the nerve sits actually behind the superior bone, and so he describes that's the optimum place to resect the bone from, unless it's a very high C3-4 approach, in which case, because you're coming up from below, you'll end up resecting more of the C bone. In his post-operative images, he then demonstrates quite significant foraminal decompression. And the last novel approach is one that's been published this year by Dr. Atul Goel, who was also the person who first described C1 lateral mass screws. And in Journal of Neurosurgery Spine this year, he's described this technique of posterior facet distraction. And that involves the placement of these small spaces in the facets that actually, he says, distracts them. I'm not sure how minimally invasive it is because he makes them wear a collar for between 6 and 12 weeks following this surgery. But a bit like lumbar interspinous spaces, it seems to put the patients in a little bit of kyphosis, and I'm not sure what the longer-term mechanical effects of that may be on the spine. So just in summary, there are these perennial arguments, which I think the next 2 speakers will address, based on those 3 principles, but in terms of as well as the anterior and posterior traditional approaches, there's also these other novel approaches. And an increased focus on evidence has led to these guideline developments that we should maybe be aware of. Thank you very much.
Jonathan, are there any questions? John.